All attendees are in listen-only mode.
Hello, everybody. This is Danny Bobrow, and I want to welcome you to this installment of the Practice Perfection Education Series. It's my pleasure to have with us today another leader in the burgeoning field of access to care for the elderly. Doreen Naughton, RDH, BSDH, is a clinician, educator, consultant, author, presenter, and sole proprietor of Dental Hygiene Health Services. Over the past 27 years, Doreen has delivered service to 3,500 patients in alternative living facilities. She has served as president of the Washington State Dental Hygienists Association, District 12 trustee for ADHA, and has received recognition and awards, including the ADHA Excellence in Dental Hygiene Award in 2000. It is also my pleasure to have on board as underwriter once again the people who were responsible for introducing me to Doreen. Aseptico manufactures and distributes mobile dental delivery as well as the wand anesthesia delivery systems. They help you get to yes with your patients, making them the perfect practice perfection partner. Today's event is set to run for approximately 90 minutes. Feel free to submit any questions you have using the question form on your screen. We'll do our best to get your questions answered following the presentation, when we'll set aside time for Q&A as we always do. And if we should be unable to do that, Doreen will respond personally following the presentation. This webcast is being recorded, and you will receive a link to it soon. You will also receive information on how to apply to receive your 1.5 hours of continuing education credit. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And with that, it is my distinct pleasure to welcome to the Practice Perfection stage Ms. Doreen Naughton. Hello, Doreen.
Hello, Danny. Thank you so much for that kind introduction, and I want to welcome everyone for joining me this evening. I hope that what you learned tonight helps you broaden your concept of what prevention is all about when we care for patients, because what we care about most is, providing good care, and prevention is a lot more than just cleaning old teeth. And I'll thank Aseptico for inviting me, and I'll also, again, thank AIM Dental for inviting me. And I also want to congratulate both of these companies on their long time that they've been in operation. Aseptico is celebrating their 40th anniversary, and AIM its 26th. So I offer you my congratulations again.
Thank you, Doreen.
You're welcome. And you know that Aseptico has been committed to manufacturing innovative and high-quality surgical endodontic and portable dental products for 40 years. They've supplied military operations, and they've allowed dental professionals all around the world to bring much-needed dental services to people. I'm really proud to live in the Northwest right in Aseptico's backyard because they've always been right there when I've needed them. And you see this Aseptico chair in this picture, and it's been tagging along with me for almost 20 years. It packs up in its carrying case, and it drops into the trunk of my car along with my other portable equipment. And it's helped me care for those thousands of people in long-term care facilities for the past 27 years. I want to ask one thing. If you have questions of me when you send them in, if they relate to a specific slide, go ahead and put the slide number on your question so that Danny and I can both refer real quickly to the slide you're talking about. And if we don't get a chance to answer them in person, I'll get back with you by, quoting you back the slide number as well, which will be helpful if you're looking at the archived version. So let's move on now to talk about what's a comprehensive prevention model. I can talk tonight. And I want to tell you how this started. Adia, a couple years ago, approached a colleague of mine, Ann Spolarich from Arizona, and asked if she would be interested in developing a module that is part of the Adia Geriatric Education Series for dental students and dental hygienists. She asked me if I would join in the effort. And together, we put our 6 decades of caring for older adults into gear, and we came up with a comprehensive prevention model. If you have access to a DIA products, you're certainly welcome to use all their geriatric education module in your practice or in your education programs if you're instructors. I also need to let you know that we did retain ownership of the module, and this presentation that I'm giving you tonight is very different than what you see in the module because it's been expanded and developed well beyond what we did 2 years ago. The reason I think a comprehensive prevention model is going to help you in your practices is because it's going to help create more informed older adult patients and caregivers. It'll also encourage opportunities for you to collaborate with other healthcare providers. It'll help promote appropriate treatment planning considering the current and future health status of the patients you're seeing. And it helps you develop communication and treatment strategies that encourage older adults and their caregivers to return to your practice, because this is what it's all about, caring for them and marketing our practices. And it also communicates that you're available and you're willing to provide services for older adults. If you've been listening in on the recent webinars, you've seen these statistics before. This might just be a little different format. In 1900, only 3% of our American population, about 3 million people, were over 65. Jump forward to 2010 and you'll see that number is now 14% or 40 million. But if you go on down to 2040, it's 21% or 80 million people will be 65 and over in the United States. I think that's reason enough for all of us in dentistry to realize we need to be busy marketing services to this aging population because they're going to represent a huge portion of our population. Let me just talk about a few senior stats. There's 76 million people that were born between 1946 and 1964. Every day, 10,000 people turn 65. I get my turn in August this year. The largest growing population is the 85 and over population. Looking at some dental statistics, 23% of older adults have not seen a dental provider in 5 years. That's according to Oral Health America. In 1960, adults over 65 had 6 teeth, and today they have 18. That's a big shout out and congratulations to dentistry in the United States. We've done a great job of educating people and helping them retain teeth. However, 1/4 of all U.S. adults 65 or older have lost all of their teeth. So they still need us to provide prosthetics for them so they can continue to eat, keep their nutrition up, and keep their self-esteem up by looking great too. So I want to thank everyone for their part in that service. So where do all these old people live? According to the recent census, most adults 65 and older, 93%, still live in community residences. It's very easy to think about old people all being in nursing homes or assisted living homes, and that's just not where they're at. Now, of those people that live in community residence, about 1 to 5%, depending on whose research you read, are considered homebound, and it's difficult for them to leave their homes for any type of service. It's also important for you to know that according to ARP, 65 million informal or family caregivers provide care to someone that's at home. So there's a lot of free service being provided for people that are homebound. That's important because Medicaid now pays out a much greater percentage of their budget to caring for people in private homes now than they did in 1990. For example, 13% of the total Medicaid funding was spent on homebound people in 1990, and it's up to 43% of their budget in 2007. And the reason Medicaid made this shift was because they can provide services for 3 people in homes compared to just 1 person in a nursing home. Very expensive to provide nursing home care for people. And if you look at the number of people in nursing homes, it's about 3.1%, which is down from about 4.5% in 2000. Conversely, the number of people going to assisted living facilities has gone up. It's about 2.4% now. I see that in my own practice, and I also see the severity of health issues with people that live in nursing homes now compared to what they were like 25 years ago. It's much more like the people that used to be in acute hospital, long-term stays in hospitals, and now they're moved into nursing homes, and people that used to be in nursing homes are more frequently in assisted living facilities now. You see that the average length of stay in a nursing home is 835 days, which is 2.2 years. 70% of those people are on Medicaid services. They receive all their payments for their services from Medicaid, and about 3.1% of them are permanently placed in nursing homes. And then another 25% that come from community residences often stay in a nursing home for a short amount of time. So what's in a comprehensive prevention model? You want to think about environment, social and sensory impairment, nutrition, cognitive ability. All of those things on those lists play a role in keeping the patient's oral health healthy and preventing more disease. Let's talk about prevention and healthy living. We know that prevention and healthy lifestyle go together. We know that you're going to reap benefits regardless of the age if you incorporate a prevention program. We also know that the way you approach prevention is going to vary across the lifespan. The goals we set when we look at prevention programs are they have to be attainable, they have to be realistic, and they have to be relevant to the person. And there's lots of variables we'll take into consideration. How old the person is, how independent they are, how much access to care they have, how motivated they are, how much influence their important others in their life put on them. Does their wife care about the fact that they have a broken front tooth? You can bet they want it fixed if she's pushing the husband. Also, what's the living situation, and how can they get to your office for care? So all those things are important, and we all know, thanks to Surgeon General Koop, he reinforced what oral professionals already knew: you can't have oral wellness and oral health without them being together. So we want to practice prevention. We want to be sure that we adopt a preventive philosophy. So we've established now that we all want a preventive philosophy, and we want our patients to have a preventive philosophy. And how we convince our older patients that they need to make changes to gain the most from the preventive methods is behavioral change. So anytime you're looking at behavior change, the research shows us that three things are important. They have to perceive that the benefit of prevention is bigger than the barrier they perceive to make the change. They also have to know that the attitudes of people that are important to them appreciate that they're making that change, and they have to believe they can make that change themselves. Oh, here's Ralph again. You saw Ralph's picture just a little bit ago. Here he is again, and this is Ralph when he was 7. Here's a story about Ralph. Ralph's been coming to your office for years. Every time Ralph comes in to see you, he tells you he has been flossing every day. I like to say only your hygienist knows for sure, right? So I ask you, if you truly have a preventive philosophy and you understand and apply behavior management principles in your practice, why does Ralph keep flossing ineffectively? I think everyone would agree when you watch Ralph, he flosses much the same at age 76 as he did when he was 7. We'll visit Ralph later. Let's go back to the preventive model for a while. Let's consider how your office environment might be improved so that it is more attractive and safer to serve elderly people. Always think safety first. Do an inspection of your parking areas and your walkway. This is where the person coming to your office first sees what you think about your area that you provide services. Do you have a bunch of broken asphalt? Do you have melting snow? Are your doors so heavy they can't even get in the door? You might want to consider getting an automatic door opener. Is there room once they get in your waiting room to sit in a wheelchair? Do you have chairs that have arms on them so they can get in and out of the chair easily? Those are all important things. You need to be sure that everybody on your team is aware an elderly person is coming in. When you do your team meeting in the morning, say, we've got a new patient coming in at 10:30 this morning. We understand they're in a wheelchair. They may need help with the door. They may be help taking a coat off. They may need help transferring into the dental chair. Are you prepared to do those things? And then once you're in the operatory, be sure you have clutter removed from the floor area and move any tables or anything that are in the way out of the way so that you can get a wheelchair in, or someone can walk in safely with a walker. Take a look at your restroom. Can someone reach a sink to wash their hands? Can they reach the paper towel dispenser? Have you considered putting in an emergency light with a cord on it so if someone has a fall in your restroom, they can notify you that they're stuck in the bathroom, not exactly where you want them to be? And the reason this is so important is because falls create hip fractures in our elder population. There's over 300,000 hip fractures a year in the United States. If you don't think these are serious, after 6 months, only 15% of people that have hip fractures will be able to walk across a room unaided. 20% who were walking before the hip fracture now require long-term care. And according to JAMA, 20 to 30% will die within 12 months of having a hip fracture. So we must do everything we can to be sure that no one falls on our watch. The other part of environment that's real important to consider is communication. Are you going to communicate with this person in a busy, noisy operatory, or are you going to set them aside in a quiet office area? You want to be sure you have a well-lit room. You want to avoid bright background lighting, because when people try to read something and it's too bright with the light on it, they can't see it. You want to make sure you take care of any extraneous noises so they can hear you well when you're talking to them. And please ask your staff not to come in and interrupt you when you are having those new meet and greet appointments with your elder patients. Remember, you have to be HIPAA compliant. So if you think they need a family member in on the discussion, you need to ask their permission to have that family member be in. And it might be a family member, it might be a caregiver, which is a paid caregiver or a volunteer caregiver. But you have to be sure that the patient agrees that person can be in on the discussion. And set up some pre-appointment protocols in your practice so you're using your time the best you can on the initial and subsequent appointment. You know, have your receptionist use an intake form for initial calls. Make sure you obtain signed consents, including releases, so that you can request medical or dental records from previous providers. Contact the physicians before the appointment, get lab results, get radiographs as needed, and discuss the need and arrange for pre-medications prior to the appointment. There's nothing more frustrating to me when I have a new patient come and sit in my chair and they bring me a medical history form that is barely filled out, never signed. Then, by the way, oh yes, I did break my hip. I did have a heart valve replacement. And I'm in the position of having to say, well, today is not a day we're going to be able to do any invasive services, and dental hygiene care is considered invasive. So let's get the name of your doctor and let me make some phone calls, and we'll reappoint you to return. What I am able to do with them is anything that's not considered invasive. So I'll complete a head and neck exam, an oral cancer screening. I can chart their dentition. I can chart their recession, any obvious visual furcations, but I can't probe, and I can't remove debris from the teeth. So they're always having to be reappointed. So if I can get a better job of pre-appointment things done, it's better for me. That's much better for the elder patient because they don't have to return, although at least when I see people in long-term care facilities, they're right there handy to come back. The third part of environment is preventing emergencies. Much like falls, there's a lot of other emergencies that can occur. So we want to make sure that we've got equipment and supplies that are ready available in our offices. Blood pressure cuffs that fit. You know, we have heavier people in our populations nowadays, so we need longer, bigger blood pressure cuffs, but we also need sometimes children's size for the elderly because their arms are so tiny sometimes. They're very frail and very small. Make sure you've got adequate oxygen supply. Check your emergency kit for any expired drugs. Have a defibrillator in your practice. Some states require this. The defibrillator might not just be needed for the patient you're seeing, but for their elder spouse that accompanies them. So be sure you have one, and check the batteries regularly to be sure that you have an operating defibrillator. Consider having a wheelchair and a walker so that if someone does need assistance getting around in your practice, they have a way to do it. Always have blankets available, always have pillows available, because sometimes when you put someone in a chair, they're so tiny they tend to tip in your chair. So if you can brace them with a pillow on behind a shoulder or under their knees, it's a lot safer for them. And certainly if they require any medications, be sure that you have them available close by, whether it's nitrous, whether it's inhalers. You want to be sure you put that out on the tray so if they need it, you have it. You don't want it to be in their pocket, in a purse, or God forbid, left out in their car. And then procedurally, update your medical history form every time you see a patient. Be sure you have questions on it that are corrected and really fit with the elder population.
Just a quick question, Doreen.
Yes.
In terms of the defibrillator, and I know I've gone through this recently because I'm a ski patroller, but is AED training part of the regular part of the requisite CPR training that health professionals are receiving, or do you need to seek it out?
If you are taking a BLS, a basic life support training, you will be trained in a defibrillator in that course. If you're taking a CPR course that is not intended for healthcare providers, you will not. Okay. So you have to.
So you'd recommend BLS then, right?
I definitely recommend BLS, and in my state of Washington, we're required to have BLS as healthcare providers. So you need to know what your state laws are.
Exactly. It's probably a good idea that everyone, if they don't know that.
It's a great idea. And defibrillators are not difficult to learn.
Right. And any
Thank
practice.
Thank goodness I've never used one. But that brings me into my next point on procedures, Danny. You need to know what a person's resuscitation status is. Some elders, many elders, do not want to be resuscitated should they have a heart attack. And I ask them right in the chair, if you are to have a heart attack during this appointment, do you wish me to do CPR? And they're not embarrassed by the question. They will say, no, I do not. I want you to let me die naturally. And you get used to hearing that when you see as many elder people as I do. But that needs to be, documented. If they have a copy of a pulse form or a DNR form, put that in their chart as well. And then you're going to be able, as procedures, to collaborate with patients' healthcare professionals. I always have to call other healthcare professionals, whether it's their nurse practitioner that's available in the building, or I have to call a doctor on the outside. Sometimes it's their orthopedic surgeon, because I need to know what their recommendations for pre-medication are and to make sure, they're safe to see. Take and record vital signs at every visit. Update their prescription drugs, their over-the-counter medications, what kind of herbal medications they take. You'll be amazed how many people take herbal medications nowadays, and they don't think they're medications. So it's important that we ask them about it, and it's important that we know which herbals interact with which medications that they may be taking. With elderly people, many times you have to use stress reduction protocols. It might be better that they come in the morning. It might be better they come in the afternoon. You want to make sure that you gear that to each individual patient. And establish and practice your emergency management protocols in your practice. Don't assume just because you all know you've all taken BLS that you'll all know where to run for the defibrillator. You'll know which one's dialing 911. You'll know which one's grabbing blankets because you think they might be going into shock. Have that plan in action and practice it. Psychosocial elements are what we're going to take a look at next. Establish a friendly relationship with every patient in your practice, and not just elderly people. Introduce yourself. I always address my elder patients by their last name. It's either Mr., Miss, or Ms. I then follow up by saying, what do you prefer to be called? How would you like me to call you in the future? And many of them will say, oh, my name's Bob, or my name's William, but just call me Will. And then I make a notation of that on the chart. Face the patient directly, sit at eye level, speak slowly but not rushed. and ask open-ended questions. Right up front, I often say to people, what would you like me to do for you? Because some people have a very different idea of what their needs are compared to what you're going to think their needs are when you look in their mouth, because you can get very quickly overwhelmed, and you want to make sure you're meeting their needs, because that's likely what's going to get them to come back to your practice again. And keep in mind that elder people process hearing more slowly than we might. So allow them time to answer questions. And if you think they didn't hear it, you can always say, would you like me to repeat that question for you? And they'll say, oh, I'm just thinking about it. I'll get an answer out for you in just a minute. Sorry, I went the wrong way with the slide there. And social assessment also includes knowing what their personal support system is. Know whether they require a caregiver. Find out whether they're caring for someone else in their family. If you look at that picture on the bottom, you'll see that that man is really got his hands full caring for a very frail wife. So if she's coming into the practice, he's going to be with her. If he's coming in, she might not be with him, but he had to arrange someone to take care of her. He had a lot of stress getting all that done, and he wants to get back home to her as quickly as he can. So keep that in mind. That's a burden for all elder people if they're caring for someone else. You can get an idea about a person's economic well-being without saying, how much money do you make? Some of the really common questions that people ask is, are you living on a fixed income? Do you live on Social Security income? You know, do you have any dental insurance? That way you can start to get an idea of what you might plan for that person. And you understand better then why they're more concerned about what they want done. Think about transportation. They drive. Many people drive. My mother-in-law drove until she was 96 years old and was a very good driver, even in the snows of Montana. But other people shouldn't be driving by the time they're age 65 or even before, depending on their mental and physical state. Some of them rely on public transport. Some of them need a family member or a friend to bring them to appointments. You just have to take that into consideration, that they may not be able to always come at the time you exactly want them because they can't get a ride, so you have to be a little bit flexible and ask them, what's the best time to make your appointment? The third part of psychosocial is the patient's rights. They all have the right to have an informed consent. It applies to anyone at any age. That, by the way, on the far right is a pulse form. If you haven't seen one, I just had room to put it in here, so I put it in here for you. It will talk about whether they want CPR or do not, whether they want an antibiotic, should they have infections, etc. And those are always available for anyone who comes from a long-term care facility. So if you're seeing patients from those facilities, you want to be sure that you get a copy of that for your record from the facility. Depression is not a major problem in growing old. It's not a part of growing old. However, older adults are more at risk for experiencing depression. About 1 to 5% of community-dwelling elders do have depression. 11 to 13% of elders who are homebound or in long-term care facilities or hospitals will have major depression. But mainly when you see someone that seems to be depressed, it's probably a situational thing. And there's nothing wrong with saying to someone, you don't seem like your usual old self today. Is anything going on? Because often that won't come out unless you ask it. Past dental experiences. You really have almost 2 generations of elders in our communities today. You have the older elderly, and you have more the baby boomers. The older elderly have had episodic care for pain and extractions in their lifetime when they were younger. They had Novocaine injections, which, by the way, hasn't been available in the United States since about 1950. They had tooth powders and hard toothbrushes. And most people anticipated that they would lose their teeth and have dentures when they got older. Then you bring in the baby boomer generation, and they had a real mixed bag of dental experiences. Most of them had more dental care in childhood. They had more checkups at 6-month intervals. They were probably exposed to fluoride, if not in water, at least in dentrifices. Water fluoridation began in 1945, so that's right before the baby boomer generation. They did have some dental sealants, though not many. They usually brush back and forth and up and down, and my favorite thing to do with someone is to hand them a toothbrush and say, show me how you brush your teeth. That is one of the most revealing things about what their ability to brush is and what their technique is, and you'll also quickly see why they're having problems, and you can make suggestions for change. I always congratulate people, by the way, when they come into my practice and they have teeth. I go, whatever you've been doing something right for a long time. Show me what you're doing. So I emphasize the positive with them rather than the negative, and then I can pick out the areas that they're doing really well in, and I can say, it looks like you're having trouble reaching that back molar. Would you like me to show you a tip? And they're usually very open to that if you start out positive. Also, the baby boomers started to be exposed to power brushes and oral irrigators. Every talk I do about elderly, I always at least mention patient neglect and patient abuse. They don't even know the number of cases of abuse annually. They estimate it to be about 1.3% of elderly are involved in elder abuse or neglect cases, but they're very underreported. And the requirements for professionals to report vary from state to state, but even if you don't have a legal responsibility, you have an ethical and moral responsibility. If you suspect that there's any type of physical, sexual, or emotional, financial abuse going on, you need to investigate it. By asking a few select questions, there are actually screening devices to determine if someone is being neglected or abused. And also we need to consider dental neglect. I've seen mouths that just horrified me. There's infection, there's pain, they can't even chew, they have so many teeth broken and lost that they just can't possibly be having a very good quality of life. But you also need to not be too fast to say this is neglect, because that person may have chosen this route for themselves, or they have no other economic means to have prevented it. But when you have a family member that says, oh, mom doesn't hurt that much, it doesn't need to happen, my detector goes up and I say, we need to talk about this. People don't realize that you can die from dental infection. So you need to educate the patient and the family member or the caregiver that comes in. I have them monitoring all the time for signs of redness, swelling, pain. They get real agitated when they get infections. They don't know how to tell you they're having pain if they have dementia, but you can tell that their behaviors change. And that's one of the triggers I use often. I use that trigger often with my own mother when she was in a nursing home. I could always tell when she was starting a bladder infection because she would get very irritable. And sure enough, they'd do a UA and we'd find out mom had an infection. So know the risk factors of these neglect and abuse issues. Advancing age, they're dependent, they're socially isolated, they have dementia, and sometimes when they have dementia, they have behavioral issues that trigger angry behaviors from their caregivers. So keep an eye on what's going on. Dialogue with your patient about concerns. Certainly document any physical sign of injury or neglect you see. Photograph it. Be sure you measure the injury in the photograph, and provide that information to any social service agency or the police when they ask for it. Let's move on to sensory impairments. We all know as we age, we have sensory impairments. Vision and hearing are the ones we hear about the most. And you routinely want to refer your patients for vision and hearing examinations. And if you're good about this, you keep a list of practitioners that you can refer to when needed, because they appreciate having a referral if they don't know someone to go to themselves. Many times elder people have moved into a new geographic area to live close to a son or a daughter, and they really don't know anyone. So they go to the doctor their child goes to, and they might not be happy with them, and you might know someone who really knows how to work with older people, and they appreciate knowing that. This is an interesting indicator from the government. If you have any trouble seeing or any trouble hearing, look at the percentage of natural teeth that are lost, or how many people have missing teeth as well. So if you're 65 or over, 37.5% report trouble hearing, 14% report trouble hearing or seeing. I can't read tonight. And they have no natural teeth at 24%. I just had to answer these questions, by the way, in the 2015 census that came out. And I found those questions very important. So vision. Everybody as they age is probably going to lose some flexibility in the lens, causing presbyopia. That means we kind of pull that book a little further back from our eyes than we did when we were younger. So what we typically do is get some visual assistance. We get a pair of reading glasses. We make sure we've got good lighting. If I go into a restaurant with poor lighting, I can't see the menu without my glasses. But at home, when I read something, I'm pretty good without my glasses. It also helps if you have large print. So anything that you're giving to a person to read, make sure you set your font a little bit higher, and if necessary, have a magnifying glass available for them. I found these pictures from the American Foundation for the Blind very helpful for me. I often have patients that report they have cataracts or macular degeneration, or it might be glaucoma or diabetic retinopathy. And sure, I know that means their vision is impaired, but I didn't really know what it meant. What were they really seeing? So these pictures were really helpful to me. Cataracts cause just a general fuzziness, and glaucoma can literally give you just what's called center vision. Macular degeneration is a blurring, and it is very difficult sometimes to see center, but not the outside. And of course, diabetic retinopathy is a great cause of blindness in this country for people that are diabetic. So if you see people moving their head around when they're looking at a form, it might be that they have one of these vision conditions and they're trying to find a spot in their eye where they can actually see.
That's an excellent tool that you're sharing, Doreen. It's really a very good example of, it's a tool to help practice empathy. And as one who has both glaucoma and macular degeneration, I could tell you that if people understood better how I saw, or maybe more accurately don't see, that they'd understand. Today I went for lunch, and the menu was just a few feet behind the cashier, and I asked what kind of chicken they have, and she said, well, she pointed at it. I said, well, could you tell me? She goes, it's right there. And I had to say, well, I can't see. And then she laughed. And she's a young girl, and I understand she didn't have a lot of experience. But, you know, that is an opportunity lost to establish empathy. But this is a wonderful tool. You actually can see, walk in someone's moccasins, see something through someone's eyes. It's a really good tool.
That's right. I found these, I mean, I've had it explained to me before by people, but actually finding these tools and pictures of it were really helpful to me too. Let's go on to hearing. Hearing deficits are fairly common. About 30% of adults between 65 and 74 have hearing problems. 47% of adults 75 or older have hearing problems. So when you're talking with someone in an office, be sure you're avoiding background noises. We all like to turn the music on in the background, sometimes even television. That's very hard for someone who has a hearing loss to hear you speak to them when you've got background noise. So many of them use hearing aids or amplifiers. That amplifier you see on the screen there, you can obtain one of those for about $35. Get online and look for hearing amplifiers. Go to your local drugstores. They have them. I always have one in my offertory, and they work really well because I just let them hold the microphone, or excuse me, the hearing part of it, and I talk in the microphone, and you don't have to talk really loud. You just talk in a normal voice, and they can hear you. And it helps usually when people have hearing deficits if you drop your tone down just a little bit. They tend to hear deeper tones better than the high tones. And those of us that have been in dentistry and worked around high-speed handpieces and ultrasonics for years have that loss of the high tones as well in our hearing. So we can appreciate that deeper tone is where we hear. You also want to speak a little slower but naturally. You don't want to talk so slow they forget about what you're talking about. So just slow down a little and they'll understand you better. Also, it seems to go without saying, but I'm guilty of this too. I'm washing my hands behind the patient and I start talking to them and I realize, oh, they're not even aware I'm talking to them. So be sure you position your body in the patient's sight line so they're aware that you're speaking. They can see your lips moving. Some of them do read lips very well. And they also are very in tune to what your expression is when you're talking to them and what your body language is. So that's just some tips for you about people that have hearing issues. We don't think about taste and smell, but since we're in dentistry, the number of taste buds decreases as we age, and the remaining ones atrophy. There's also fewer nerve endings in the nose, so almost 25% of adults over 55, 30% between 70 and 80, and nearly a third of people over 80 have a problem with their sense of smell. And it can also be that they don't smell things correctly anymore. What you smell is cinnamon. They smell as something pretty gross, and they don't want to smell it. Also, when there's a loss of taste or smell, there can be an impact on their nutritional status, and I'll talk about that in a little while. Certain medications, such as beta blockers and ACE inhibitors, can also interfere with taste and smell, as do dental infections, tobacco use, traumas, and diseases like Alzheimer's and Parkinson's. I didn't really think much about the sense of touch declining until I heard a speaker a couple of webinars ago mention that people don't feel in their mouth what we feel. I can wake up in the morning and say, ooh, gross, sweater's on my teeth. They don't seem to feel that, and that's because there is a decline even in touch perception throughout the whole body, and that's a change in both neuroanatomy and neurophysiology. And it's also a part of what the CNS is still triggering and what the peripheral nervous system is feeling. So it's kind of both systems that are starting to decline. And of course, there's some diseases such as peripheral neuropathy with diabetes that definitely interfere with touch. Balance. We talked about falls, and we're saying, why are people falling? Well, oftentimes it is a balance issue. And although natural aging process does not result in the loss of balance or control or mobility, there are studies that indicate that elders are different from their age and age-matched counterparts. So in other words, some older people will have more balance problems than others. Dizziness can also be caused by a collection of really stubble degenerative or infection processes. You can have an ear infection. You can have sinus infections. All of those things can be a part of the reason you're having, trouble with balance. But it is not a result of aging purely. It also can be that they've had a broken leg or a bad sprained ankle in the past. I've done both of those. And for years after I had that leg set, I still kept twisting the ankle and almost falling. And it was because it just had not healed well yet. And of course, if someone's had a stroke or they're on medications, they can affect balance too. Moving to nutrition, we all know as dental practitioners that the loss or unhealthy dentition, poorly fitting dentures, salivary changes are all going to impact nutritional status. I mentioned a minute ago alterations in taste and smell. There's systemic health issues that cause people not to be able to eat as well. They can't swallow as well sometimes when they have, let's say, Alzheimer's, and the part of the brain that's starting to be affected affects their ability to swallow. It's real important that the behaviors of their significant others help them keep their nutritional status up. For example, if they can't cook, they're really reliant on that caregiver or their husband to cook dinner for them. And you want to make sure that they're choosing healthy foods. Economic barriers will keep people from being able to choose healthy foods. And you also consider what ethnic and cultural influence has on diet. I'm amazed sometimes when I go to an ethnic restaurant, and I'll just use a Mexican restaurant I go to, for example. I don't go there very often because my meals tend to be very high in fats when I'm eating that food, but once in a while we splurge and have a high-fat Mexican food. So when you suspect you've got nutritional deficiencies, consider consulting with a registered dietitian. Refer the elder patient to the dietitian. Teach the patient and the caregiver about the oral systemic effect of their food choices. There are some really good benefits to not drinking sodas, not drinking fruit juices, but these are things, particularly in long-term care facilities, they want to keep people hydrated, and they want to get the caloric intake up, so they will sit orange juice, apple juice, ensure, some of the high cariogenic foods that they're constantly sipping on. The other thing, because we're dealing with dry mouth so much of the time as a side effect of medications, they're sucking on hard candies. We can certainly go to products like xylitol. We can certainly go to non-sugar candies. And one of the things I have been able to do in my facilities over the years is to stop everyone from handing out sweets as a reward. If you had a dementia and you weren't behaving, well, we'll take you into the break room here, and we'll give you coffee with 6 teaspoons of sugar because that's what they like. So I've asked them to please stop that type of reward system, and it has been helpful. And some of your drugs cause negative aftertaste, real metallic taste in your mouth. Zinc is one that particularly does that. So if you have that taste in your mouth, they want to suck on something all the time too. So look at what kind of throat lozenges they're using. Make sure they're not full of sugar, not zinc, because then they want to eat something else. And you can't always alter their medications, but sometimes you can. But the term activities of daily living might not be familiar to all of you unless you do work in long-term care facilities, but it basically is called an ADL. It's the basic self-care tasks that we all do for the most part without thinking about it. We sit down to eat, we decide what clothes we're going to wear in the morning, and we can put them on ourselves. We do our own bathing, we comb our own hair, we brush our own teeth, we can toilet, we don't have wet pants. We can walk and we can transfer from a bed to a wheelchair or from in and out of a vehicle. But we know from research that when people report they have difficulty feeding themselves or grooming, that's going to directly relate to their oral health and their overall wellness. And that brings me to what I call known versus effective behavior. There's a term called social brushing. Social brushing comes in our country particularly from an early age. We teach our children to brush their teeth. And that brush starts going in the mouth, and it's usually done a couple times a day. But we know that just because you brush a couple times a day, it does not mean that you're going to be effective. Are you really removing the biofilm? We also need to assess the dexterity and how effective the person is brushing. Because if they can't do anything more with their hand, like a fork, pick up a fork and eat, they probably aren't going to be able to brush very effectively. But by the same token, self-care with toothbrushing really equals independence. I don't like to take away toothbrushing from my elders until I absolutely have to, or until mentally they're not aware I'm taking it away. I'll still tell them to brush their teeth twice a day, and then I ask my caregivers to follow up and help them brush probably in the areas they have difficulty with, or perhaps all throughout the mouth. But we tell that person, we're following up because you have an infection and we need to put some medicine on your gums. That way we're not saying we're going to brush your teeth, because they'll say, I just brushed my teeth. You say we need to apply some medicine, and they're much more willing to let you do it if you say that to them. And also professionally, I've learned long ago, even though Pepsodent put out the ad that said you need to see the dentist every 6 months, it's just not adequate to keep many of our elders' mouths healthy. I see some of the elder people in my facilities on monthly visits, 2-month visits, 3-month visits, and until I see the bleeding coming in control, the inflammation coming in control, then I continue to keep them on those shorter cycles, and it's amazing how much more impact it has. When you're evaluating if someone needs assistance, look at their grip. How far can they close their fingers around a toothbrush? Look at their range of motion in their, not just their fingers, but their hand, their wrist, their arm, their neck. Because if they can't move their neck or their arm up high enough to get a toothbrush in position, they're not going to be effective in brushing. Also check to see that they can swish, spit, and if they can swallow. Because if they can't swish and spit and they can't swallow, you're going to be very careful that you don't use products that they're going to be choking on. And if you need a caregiver, you need to assess their willingness to help the person. You need to check what their basic knowledge is. In other words, why are we brushing teeth? Why is it important? And teach them some skills so they can assess and clean the mouth. Select appropriate tools and products. I usually stay with, nice soft toothbrushes and a product that they can just dip a toothbrush in, and often it's not a toothpaste, it's more of an antimicrobial rinse, and they're putting that on the gums so that we're reducing not only the bacteria there, but we're getting some mechanical stimulation of the toothbrush on the gum. And ask that caregiver to demonstrate back for you how you just showed them to do the brushing, because unless you actually get them to do it, there's no real chance that they learned it by just listening and watching. They need to do it. That's part of the learning process. I'm not going to go into a lot of detail about systemic health, but what I do think is important when we talk about elders is lifelong habits. We need to be sure that we're aware that they've been exposed to sun, tobacco, alcohol, etc. And I'll just give you a little information here. Exposure to sun. We all know it's a lifelong exposure, and the longer you live, the greater chance you have of having some type of skin cancer occur. 53% of deaths occur from skin cancers at over the age of 65. So provide education, head and neck exams, refer, and then they'll decide whether they're going to treat or not. And that'll be based on whether the person's health condition is healthy enough to withstand the treatment, or whether that cancer would grow so slowly, even if we didn't treat it, it wouldn't be a risk to life. Tobacco, you all know that there's major risks from tobacco. I want to just encourage you to tell older people the session programs are well worth the time you take and that they take. They've been shown over and over that people will stop smoking even at an older age if you take the time to work with them. My own mother stopped smoking at age 69. Unfortunately for her, her systemic system was pretty debilitated by that time, but she still lived to 87, which I did not expect, but she did quit smoking. Encourage your patients to do self-screenings in their mouth. Teach them what their mouth looks like, what it's supposed to look like, so when they see something, they can bring it to you and have you reevaluate it. Alcohol. We all know that alcohol is a problem in our society. We also know that 40% of elders drink. We know their drinking patterns vary. For some, it's not a problem. For others, it can be. We know it causes physical impairments. We know it causes more risk for falls and injury. Also, you want to be sure that if you have seriously heavy drinkers, you do not encourage them to self-detoxify. It can be very dangerous. You need to be sure they have medical supervision if they are planning to stop drinking. Cold turkey is not the way to detoxify elders, or anyone else for that matter. Also be aware that Medicare does help pay for some detoxification treatment, so you can check and see what those requirements are. Drugs, and I'm talking about drugs that are not medications at this time, and aside from medical marijuana, which is becoming very popular and quite effective in our society, it will we'll certainly have more research on that as we come about. But be aware that people that are older do have drug problems. In fact, I think I have a slide next that actually shows you the increasing number of people that use any illicit drugs, marijuana or cocaine. Looks like the elder population has given up hallucinogens, however. That's the bright side in this slide.
I guess hippies had to age eventually, huh?
Yeah, eventually they got wise, I guess. here's a topic that I don't think you think about when you think about your elders. Unsafe sex and the use of Viagra has really caused an increasing number of sexual encounters in our elders. They're not aware of the risk. They're not tested for STDs. They dismiss signs and symptoms of just being, oh, I'm old. They don't have good educational resources. They're less likely to talk about their sexual activity with healthcare providers. And they're not screened by the provider, nor does the provider even ask them. You'd be amazed at the stories I hear from people that live more in our assisted living type long-term cares, and they're talking about their new boyfriends that come to visit, and I'm just kind of getting information, and I remember going to a nurse practitioner once and saying, are you aware that so-and-so is seeing so-and-so and so-and-so is seeing so-and-so? Oh, she goes, yeah, and 6 others. I was shocked. So encourage safe sex practices and screening when people start to talk about any problems they have on medical histories that might indicate they've had STDs. Certainly, one of the largest growing populations of HIV infection is women over 55. It's very shocking. Help them prevent infections. You know, infections are pretty high in residential settings. They get community-acquired infections from people coming to visit. They get contagious infections from contact with others. They get environmental exposures. They're on drugs that reduce their immune systems. People that are in the communities are doing more domestic and international travel where they're exposed. So be sure that, you know, they have their vaccinations. You know, they get their flu shot. They get their pneumonia shot. They get their shingles vaccination. Whooping cough is on the rise in our communities now, especially for babies that can't be vaccinated. So all these grandmas that are holding these little babies, if they haven't had their DEEP taps, they need to have them. If they're traveling, be sure you're screening them for infections they might have brought back into the country with them. So again, vaccinations before they go, seek medical advice before international travel, and make sure they record what they've had, because some countries don't let you into the country unless you've had some of those vaccinations. So there's usually a blank page in a passport or something that you can put that information in for them if they haven't done it. Oral health. This is going to be real fast because you all know about oral health. These are all pictures of people that I see in my practice. You know, all the way from having nice, healthy teeth, all teeth, to having only lower teeth but look still pretty healthy, to having massive, massive acute infection, to having the ones that, yeah, I see the history of dentistry there. We've got some recurrent decay going on around the resin restoration. And here's my lady with what she called the sandwich tooth. She did not want that tooth pulled because she could still pull a soft bread sandwich apart if that one tooth was there. We all know changes occur normally with aging teeth: wear, chipping, staining, exposure and wear of dentin. We know that the pulp chambers are smaller. We know they have dark appearance in general because it's either intrinsic staining or more extrinsic staining. And we can do a lot of things that help those normally occurring aging teeth look better, but we can't always make them look like brand new. So assess the degree of salivation. You know, what's their existing dentition look like? What do their soft tissues look like? Do they have any pathology? You know, can they taste? Can they chew? Can they swallow? What do they look like? And how important is that to them? That's where the questions we need to start asking. And you can see that mouth. When I saw that mouth, it was almost like, where do I begin? Sometimes you become so overwhelmed by what you see, you have to go back to the basics and say, well, let's get back to how well is the daily care being done. I see a lot of root and recurrent dental caries. I see periodontal disease, edentalism with all kinds of stomatitis, oral cancer, dry mouth, oral movement disorders. We see all of that. I see much less yeast infection than I used to, though, because they're being cared for more frequently and using products that help to eliminate the development of yeast infections. Oral movement disorders are usually related to either medications that they take for psychiatric conditions or depression, or they have neuromuscular activity issues, or they have a stroke. And the risk there is that they get soft tissue injuries. I've had people that have literally chewed all the way through their lower lips because they have such terrible oral movement disorders. You can try using things like mouth props during dental treatment, mouth guards. You can try modifying medications, and of course sedation during treatment so that they're calmer when you're treating them. But I don't have a lot of good things to say about mouth guards. They just don't keep them in their mouth very well, but we've tried. Anyone else has tried and been successful, let me know. Maybe there's something we need to know. Caries factors. You know much about caries. You know that when you have 3 or more incipient or cavitated primary or secondary lesions in the last 3 years, you've got suboptimal fluoride exposure and xerostomia. You've got the recipe for disaster. And that mouth down below came into a nursing home looking like that. They didn't end up like that. They've been in the community, which says to me there's a whole lot more encounters that need to be happening with elders in our communities. There's a whole lot of reason why those elders are not getting care before they get to nursing homes, but we need to do more as professions, you know, as dental professionals to reach that group. Fluorides are proven prevention. I happen to put fluoride varnish on every time I see a patient, whether it's 1 month, 2 months, 3 months, 6 months. In my really challenged people, we use daily fluorides. We use xylitol in some. I tend to use more of the sprays with the xylitol because there's such a risk of aspiration if you give them gum or lozenges. The gum gets in their hair, they choke on the lozenges, so we have been using some spray with a reasonable degree of success. I haven't used it very long, and I'm going to look and see how we're doing as we go along. The remineralization products don't have a lot of research out on them yet about how effective they are, but certainly people are trying them, and we certainly are using a mixture of chlorhexidine in varnishes, and that may help too. We don't have a lot of research on it yet, but we have some. Fluoride sources, you know, regular toothpaste, prescription strength fluorides, which is what I recommend, 1.1 neutral sodium gels. I can always get a prescription from either their dentist or their nurse practitioner or physician, and we use it at night, and we do not rinse afterwards. We just spit excess or wipe excess and go to bed. I already talked about in-office products, and there are products for xerostomia that you can use that will help them get relief from dry mouth. I'm going to just flip a slide over here and go to that right away. But the best prevention strategies I find are be sure they're being well hydrated with water. They can use sugarless candy or lozenges if it's not an aspiration risk. Same thing with sugarless gum or xylitol gum. Antiseptic mouth rinses. Saliva replacement therapies for lubricants can certainly work. Even power toothbrushes seem to stimulate saliva flow better than a manual brush, according to some of the studies. So I've tried just about everything. And oral irrigation and any interdental cleaning devices and aids help again to stimulate. Be aware that there's also a problem called hypersalivation. There are certain neuromuscular impairments from Parkinson's disease and certain medications that actually make people have too much spit in their mouth. And it's a risk factor because they're drooling and they're choking on their own saliva. So when those things happen, we need to be sure we have adequate suction when we're working on them. And sometimes the physicians will consider anticholinergic medications and neuromuscular blocking agents to stop that excess flow of saliva. And we had some pretty good success, particularly in some of our Parkinson's patients. So you need to refer to healthcare professionals for swallowing therapy too if they have too much saliva because they're choking all the time. Power toothbrushes, I think they've been a real boon to keeping our elder mouths healthy. I also have found that the larger handles have alleviated my need to be modifying handles on manual toothbrushes. Some people don't like the vibration, they can't handle it. So everybody, again, has to have training in how to use them and make sure they can take the heads off of the brush to get them clean. I love to use inner dental cleaning devices because of the dexterity limitations and the research that shows us flossing is not very effective unless it's in the hands of a dental professional or someone that's really adamant about doing it. So I'll say to them, let's use something different. Let's try using a floss holder. Let's try using a power flosser. They've got some great air flossers out now that are power. We use interdental brushes a lot, special toothpicks. Oral irrigation device is now shown to really remove both the attached and the loose biofilms. And when you tell people that have been struggling with flossing for years and not being effective at it anyway, please stop flossing, let's try something else, all of a sudden they're thrilled that they're being successful cleaning between their teeth. We use antiseptics and antimicrobial therapies. Must be time for me to have a drink of water for the dry mouth. And I use mostly over-the-counter antiseptic or antimicrobial rinses. We go to chlorhexidine in certain cases. We don't like to use it for long durations of time. And also in long-term care, the pharmacies charge quite a bit for your chlorhexidine products. It's typically about $40 a month. So that's a lot of money to put out when it's not covered on their Medicare all the time. If they've had root planing or oral surgeries, then it's covered. If it's just for routine use, it's not. And of course, you know, chlorhexidine is pretty broad kill. So I also try to stay with things that maybe are not as wide a range of kill. We have problems with people developing yeast infections when we kill too many of the good bacteria. So we'll tend to use over-the-counter products that are not as broad kill. I want you to know that there's no evidence to support that alcohol-containing mouth rinses contribute to the development of oral cancer. That's important to know. Also, you can know that when you use alcohol-containing mouthwashes, it's not really related to oral dryness. That's something that's been shown over and over again in research now. We used to get everybody to use non-alcohol containing mouthwashes. The reason I use them sometimes is they don't seem to have the biting stinginess that some of the alcohol products do, but it doesn't cause dry mouth. And there's no difference in the perception when they rinse with an alcohol or a non-alcohol product. And for most people, the use of the alcohol-containing product far outweighs the risk of one without alcohol. The one contraindication is if you have someone who's a recovering alcoholic, or they're just plain, you know, intolerant of the strong flavor or the sensations. You guys remember Ralph? He showed up a long time ago. And where'd Ralph go? There's Ralph. I just took him away for a minute. You know, when I think about Ralph and I think about how much we'd love for him to be flossing every day, I think probably you just saw some things that will work a lot better for Ralph. And adding an interproximal brush, a rinse for him will probably be as effective or more effective than how many more minutes you're going to spend with him in your chair teaching him to floss. So consider making a change in his daily plan. A little bit about denture care. Ensure privacy when you take someone's denture out. They're very self-conscious with removal of their denture. Some people don't want anyone else to know they have a denture. So you want to be really good about that. You want to make sure you inspect the fit and function, make sure that person has the ability to remove and insert it themselves. Be aware that with even just 5 pounds of weight loss or gain, it can affect the fit of the denture or the partial. If they drop them, they'll get chips and fractures. They'll bend clasped. You can see the picture in the bottom. Teach them to put a nice thick washcloth or a towel in the bottom of the sink when they're brushing it, because that will keep it from getting broken if they do drop it. Make sure the dentures have ID in them. Many states have a requirement for labs when they make dentures now to put ID in them. However, you will come across elders that have been wearing the same denture for 30 years. There's no ID in them. And if they're headed to a long-term care facility, it has to have a label in it, or they can't be admitted to the facility without one. Actually, they do get admitted. It has to be labeled within the first 24 hours, I believe. Maybe it's 48. And then teach them how to clean it, of course. Teach them to inspect their oral tissues. Teach them good home care instructions in terms of adhesive. I find people use way too much adhesive. If they need it, they need it. I'm not opposed to it, but they don't need to put a total line of adhesive from one side of the denture to another. It just squishes out of the flanges of the denture, and it's very hard for them to remove from the denture and the tissue, let alone getting the denture out of the mouth. A little bit about medications. Medication costs is a real problem for people if they do not have insurance. They simply will not take medications that cost too much. And we know that many older medications cost less or equally as effective. So consider what type of medications you're recommending or what they're taking, and provide education for them to talk with their physicians. Sensory impairments really limit their ability to hear and process the instructions you're giving them. They can't read labels, they can't read directions, they have difficulty swallowing pills. So be sure that you're giving them appropriate dose and quantity, and they know what that dose and quantity should be if it's something you're telling them to take before an appointment. 2 grams of amoxicillin at a 250-degree dose is 8 capsules they have to swallow. They might take 2, they might take 4, you might get lucky and they take all 8. So ask them what they've actually taken, and to bring their bottles with them so you can see what they had and you can compare. Because even though you order something that's 500 milligrams, the pharmacist might not have them available and they give them out at 250. Ask people to repeat back instructions when you give them a medication. Ask their caregiver to give it back. Put it in large type in a written format, and make sure that if they have more than one caregiver, that those caregivers share those instructions on down the line so everybody is doing what you want them to do. Have you met Alice? I love the movie Alice, and I love the book. I'd read Still Alice when it first came out, and I recently saw the movie, and I can tell you it's a very good example of what happens with memory impairment. We all have some memory impairment as we age. It's called age-associated memory impairment. Some people have other acronyms they use. But dementia is a general term for loss of mental abilities. It's severe enough to interfere with daily life. And the symptoms and the causes of dementia vary, and there's multiple types of dementia. Some are reversible, some are irreversible, like Alzheimer's. Some of the reversible dementias might be they're on medications that are causing problems. They're not getting an adequate diet. Their blood pressure's too low. They've got low blood pressure and they're confused. So that's something you need to look out for. If they're not well hydrated, they'll have low blood pressure. So think about why they might be confused at this appointment. Don't immediately jump and think they have Alzheimer's. Refer them to a medical doctor or a nurse practitioner so they can get some testing done. There's different types of dementia. Alzheimer's is the most common. However, vascular dementia, which is caused from mini strokes or major strokes. There's dementia with Lewy bodies, and we're finding out now that there's more mixed dementias than we ever thought before. You don't get a clear diagnosis of one kind of dementia, and really you can't diagnose Alzheimer's until an autopsy. So they look at the symptoms that they're showing, and they will say often this is an Alzheimer's type dementia. Parkinson's disease can lead to dementias, and then frontal temporal dementia is basically loss of the neurons in the frontal temporal portion of the brain. And people that have these different dementias show different symptoms. My father had normal pressure hydrocephalus dementia that was not caught in an early stage, and by the time they did catch it, he had a tremendous amount of shrinkage in his brain and a fair amount of dementia. Early signs and symptoms. We all worry about, I forget things. That must mean I'm getting Alzheimer's. Well, if you forget something but you remember it later, it's probably not Alzheimer's. If you can't find your keys and you find them and you know they go in the car, quit worrying. If you find the keys and you don't know what they're for, then we have a problem. So there's challenges in planning and solving problems. There's confusion with time and place. It's not just memory issues. You might have problems with words and speaking and writing. You don't have good judgment. You start to withdraw from work and social activities because there's an embarrassment. People with dementia tend to keep their social skills quite for a long time, but they become embarrassed because They don't want to say the wrong thing or do the wrong thing in groups. Changes in mood and personality are often very common with people that have dementia. Economics, wow. Social and economic diversity really varies with our elder. It also varies with gender and race and ethnicity. We know that women and minorities tend to have a lower social economic status than men do. We know that they've had a various life cycle of care and treatment based on what their economic ability was, and care should continue throughout a lifetime, not end at retirement. So you will see people come in that have had wonderful dentistry in their earlier years, but by the time they reach retirement age, they haven't been in for that 5 years, and they start to have all kinds of problems, and you're saying, wow, what happened here? And often it's simply an economic barrier. So look at realistic treatment planning. Present options. Find out what they want. Find out what they're able to maintain. I had a 98-year-old man who had 4 new implants put in and was gone in less than a year. I don't know who put them in, but I remember just shaking my head when I saw it. So be rational about your treatment planning. Plan for things that have reasonable success. Look at the cost-benefit of prevention. Again, investing in preventive aids, since it's like a power toothbrush or some type of a mouth rinse, might be the best thing that they could do. And teach people that the number of preventive visits they have with you will save them money in the long run. Again, cost-benefit ratio to life expectancy. If they've got very, very advanced disease, there's very little you can do that's going to be beneficial to them other than keeping them out of pain and possibly some atraumatic dentistry to keep things from getting worse in the months and years they have left. And be aware that you're going to start being asked about dental tourism. People want to know why they should go to Mexico or not go to Mexico to get those crowns and those veneers done that you've been recommending. So be prepared for those kinds of questions. The treatment decisions are going to come on the patient side and the professional side. Remember, they have the right to make the choice of care they want. They have the right to have informed consent. They're going to weigh cost versus benefits, and they also have indirect costs. You know, what does it cost me to travel here? Does my daughter have to take a day off work? Do I have to hire a nurse aide to come with me because nobody in your office knows how to do a wheelchair transfer? And on the professional side, avoid ageism. Don't make decisions based on how old a person is. That's not appropriate. Be sure you do value their patient rights and privacy. Focus on the prevention. To minimize deterioration of their teeth, prioritize needs, offer options, be efficient. If you can do 3 small fillings in an appointment rather than 1, that's better than making them come back 3 times, as long as they can physically tolerate that length of an appointment and consider the costs and indirect costs that I just mentioned. So your goals are to have them be free of pain, be comfortable, have adequate function, and acceptable aesthetics. I hope that you enjoy working with elder patients as much as I do. They bring us a large number of special challenges, but they bring us large rewards. I tell my colleagues who say to me, "Are you still working in nursing homes?" I come back with, "Where do you work where everybody thinks you're still 35? And they all laugh, but it's true. You learn so much from our elders. They have so much to share, and I hope you enjoy caring for them as much as I have. Thanks, Danny. Thanks, everyone. I'm glad to have shared with you this evening. And if you want to share questions, that's great.
You are most welcome, Doreen. Thank you so much for sharing your wisdom and insights and passion for such an important subject. And, you know, we talked about giving and meeting challenges and receiving the rewards. When you go the extra mile, as is often necessary with the elder population, their appreciation and that of their family members only translates into goodwill, which is one of your best marketing tools. And I know I don't have to tell anybody that. They already know. But you also mentioned what a great opportunity it is to grow your referral network, because you really have a need to, if you're going to benefit the patient, to reach out to their healthcare providers to collaborate on their care. And if they don't have healthcare providers, what a wonderful opportunity to provide even more value to them, which they, and again, their friends and family can only sit up and take notice. So definitely an example of what I like to call doing well while doing good. And that always
that's
well.
really true, Danny. I can tell you that I have never marketed my services to a long-term care facility. They have all come to me. I started out by buying a practice that had just 3 nursing homes and a very small number of people. I knew I wanted to grow that practice, and I started to just talk to people that I knew and said, oh, I'm working in nursing homes now. If you know anyone that lives in a nursing home, let them know these are the services I provide. Well, before long, I had families calling me. I had nursing homes calling me. I would say, well, I normally don't go to a nursing home to see one person, but in this case I will, because probably someone else will need my help too.
That's
and
right. It's viral in a very positive way, and it's also a great example of what we learned in business school of demand pull versus demand push. People are coming to you because your reputation and value have preceded you. So it's certainly win-win-win.
Right, and I just want to let people know if they have private dental offices and they have elders that come to them from long-term care facilities, they're very appreciative of your care, and don't be afraid to ask that long-term care facility to provide information for you in advance. Ask them for their medical diagnosis, their medications, their pulse forms. Have all that in advance, 2 or 3, 4 days. That way you can be more prepared to see those people, and you'll keep getting more patients from those facilities.
That's absolutely true. And actually one of our attendees today made the comment that they can sometimes get the patient's pharmacy to email them the patient's medication list in advance as well.
That's right. And I often call a pharmacy to get a list of medications if it's someone that is doing more independent meds, because I get a mix of people that are more independent and more dependent, and I need that list. Also encourage your patients to use the same pharmacy for every prescription. That will really help.
Sure. Okay, great. Well, we do have some questions. Let's see how many we can get through in the time remaining. The first question is, how do you see hygienists impacting access to care over the next few years?
Well, as of right now, 37 states allow dental hygienists to provide direct access care. That means that they can assess the patient's needs and provide the care without a dentist being present and without a dentist seeing the patient first. And so they establish a patient-provider relationship, and a variety of states have different requirements. For example, some have to have a collaborative agreement with a dentist. That means that a dentist in their community says, oh yes, I know you're working over at this nursing home or in this school or in this senior center, and I'll be available to you to collaborate if you have any questions. I might be available for you to refer patients to me, but that's not always necessary in those collaborative agreements. I'm fortunate in Washington State that I work without supervision in the settings I'm in. However, if you do work in a senior center, you do need a collaborative agreement. It just depends on what the laws are in the various states.
And I believe I just heard recently, well, I know I just heard, and I believe it's true, that Alaska and Utah just passed a law that allows hygienists to see patients without a dentist being present or seeing the patient first. However, they do require that, what was it you just called, a collaborative agreement?
Collaborative agreement, right.
Where they do, in fact, have a dentist to whom they can refer the patient should the need go beyond their ability.
In truth, Danny, whether you're unsupervised or whether you're required to have a collaborative agreement, we all work as co-professionals. I always work with the dentist in the community or the dentists that come into the long-term care facility because we need each other. And it's just a matter of who looks in the mouth first. And to me, that's, not material to that patient's health. If we don't look first and get them to the dentist, no one's going to be looking, and they're not going to get to the dentist. So we're really opening up a whole new means of accessing care for these individuals and improving their care, improving their health.
No, we really are, and I feel, I think it's unfortunate if there are dentists who somehow feel that this is inappropriate or against the public interest, because all it is as you said, it's increasing access to care, and it's not a competition. It's a cooperation that really is being facilitated by these arrangements. So
right, and it's been happening for 30 years in Washington State. Washington State was the first state to pass a law allowing dental hygienists to practice in certain settings without supervision, and it's been a real success. The numbers have been really high in terms of the people we've been able to see and impact, and many of those people do get the needed dental care after we get them referred. So it's great. We have that political rub all the time of dentists being afraid of what we do, and there's no reason to be afraid. Certainly economically it brings benefits to their practice. Certainly we have oversight when we're in facilities with physicians and nurse practitioners. There's always someone we can turn to and ask questions if we have them. Certainly someone's arranging for pre-medications. I can't administer medications, but the nurse practitioners or the primary care nurses will do that if we have an order from the physician.
Mm-hmm. Was your decision to practice in Washington in part or largely predicated on their liberalism in this regard?
Well, I was born and raised in Washington State. I've never lived anywhere but the great Evergreen State, and I became a dental hygienist, and I knew from the beginning when I was in school we were working on legislative changes to allow unsupervised practice, and I knew that I would be a person that would be able and willing to do that. I was maybe a little non-traditional, a little older than some of the students in class, so I knew right away that's what I wanted to do. And even though I wasn't required to go on and get a baccalaureate degree, I felt if I was going to own a practice and be represented, as an independent practitioner in my state, I wanted to have a minimum of a baccalaureate degree. So I went on to the University of Washington School of Dentistry, where we had a degree completion program, and completed my baccalaureate degree and took many classes with the dental students at the dental school. It was a great experience.
That's excellent. What obstacles have you encountered in getting hygienists and dentists to collaborate in delivering comprehensive care to the elderly?
Well, I think there's really three things here. One is, the first thing is education. We need to start in dental schools in educating dental students and in dental hygiene schools and educating dental hygiene students that these opportunities are available, and we need to learn more things about caring for geriatrics. I really want to compliment Adia for putting that program together so that instructors can just pull down a lecture about, geriatrics and in about 6 or 7 different topics so that they're getting some education. I also think there's a fear that you won't make any money when you go take care of old people in long-term care facilities. And it's true that many of them are Medicaid eligible, about 70% of them. But if you put together a well-organized practice so that you are seeing multiple patients a day and on a scheduled time in a clinical setting, whether it's a multi-purpose room like you saw my chair set up in at the beginning of the presentation, you can really do a good amount of care, even though it's being paid by Medicaid. And I don't have any problem with that. I do think, though, having said that we need to change our Medicaid laws so that we don't just have states that only offer emergency services for people that are on Medicaid. We really need to impact health by providing more comprehensive Medicaid programs for the elderly. We do it for children. We need to do it for the elderly.
Here's a question. How do you receive reimbursement?
I receive reimbursement either in private pay from a resident or their family member or their guardian. I receive pay from private insurance for the few people that do have, private dental insurance benefits. When I first started practicing, there wasn't an insurance company in the land that would recognize a dental hygienist as a provider, and no one would pay insurances. And bit by bit, I educated our insurance carriers in this state, and Delta Dental of Washington was the first state, I believe it was 1996, to begin to recognize dental hygienists as out-of-network providers. So I have been able for people that had Delta Dental insurance to submit claims, and now a number of insurance corporations and companies across the company will accept claims from dental hygienists. And of course, one of the biggest ways I get paid is through Medicaid, because many of my patients are on Medicaid. So I do electronic billing online with the state of Washington and receive electronic payments from the state.
Excellent. We have a number of other questions which we just haven't time to get to, but I want to thank you again, Doreen, for a very obviously heartfelt presentation. You're doing great work, and you're inspiring other people and educating them to do likewise. And everyone, I know I speak on behalf of everyone, that we appreciate your commitment to this. It means a lot to so many of us and our loved ones. So thank you again.
You are welcome, and thanks for everyone tuning in.
I want to now remind everyone to mark their calendars for next month's webcast, which will take place on Thursday, May 21st at 7 p.m. Central Time, when my very special guest will be my friend and colleague, Dr. Chris Phelps, who will speak on how closing your team's performance gap can easily lead you to triple your new patient flow without investing another single dollar in marketing. And I've seen him do it. In the meantime, this is Danny Bobrow, thanking you for your commitment to practice perfection. Goodbye, everybody. See you next month.